As well as being senior lecturer at St George's many years, I've recently taken up post as medical director of Adaption. So I've gone over to the wild side, the voluntary sector, a sector which actually provides a sort of outreach which in many ways it was increasingly difficult to provide within my old NHS teams, community drug and alcohol team. And therein lies some of the rub really, that in some parts of the NHS it's become so focused on certain types of service model and outcome that the flexibility that I found in the NHS and was able to help develop in my push to the NHS 10, 15 years ago has gone. And I think that if we're to deal with health inequalities, as well as to deliver a consensus, we need to deal with that level of social vulnerability, that level of psychological harm, and that level of physical damage that the group we're talking about today bring us to deal with. Now, the other thing, of course, is that in preparing this talk, 10 years ago, if I'd done this talk, I would have gone to a directory, a printed directory, ring-bound, of addiction services, both NHS and voluntary sector services for people with drug and alcohol problems in London. Now, it's clear that that's impossible. That's an impossible task. Websites are out of date. They're on the internet. And when I wanted to populate my little diagram of London, Greater London, in the bottom left-hand corner, I was going to populate it with figures in terms of the NHS services, the nature of the voluntary sector services and other support services, including GPs working in the field of addiction. What is clear, though, is that these services are changing all the time, and it's part of the problem is that state of flux. So, having said that, I want to say a bit about the current structure, a bit about funding, and a bit about practical issues in current opioid treatment and management. So, now and to come. Nowadays, primarily services are provided by NHS community drug teams. GPs with a special interest, increasingly in the capital as well as elsewhere in the country, provide important addiction services. And not forgetting those doctors working and healthcare teams working in prison mental health services and prison health services. Because of course those services are now mainstreamed within the NHS rather than being separated within the prison service. Most addiction services in the NHS are located within mental health trusts. There are clear links nowadays with probation and prisons. And also the voluntary sector teams are increasingly working with offender groups, young people and hard to reach groups because of their style of working and also because of their historical working patterns. In the future though, there's going to be a mixed economy. As Geraldine alluded to, NHS community teams, GPs, voluntary sector teams, perhaps even in mental health services, mainstream mental health services. Locations will change, not may change, and also the links between those services will diversify further. They'll become more fluid. They'll become potentially more creative, I hope. And that comes from the National Treatment Agency Business Plan. In terms of funding streams, a lot of the funding still is central, but also from local PCTs. PCTs are going though. Funding streams are not confirmed. There's a lot of uncertainty. Now, does this crisis lead to opportunity or does it lead to despondency? I hope it leads to opportunity, but no funding stream is sacrosanct. That's the point. And the services, the NHS addiction service in London are at the sharp end of that. All services are under threat. Those have not already been recommissioned, tendered, perhaps sometimes lost to the NHS completely. This is a serious threat to the sorts of links and relationships we want to develop across addiction services, primary care services, hard to reach services, and obviously hepatology services. So the models are changing as well, and I think it's important to recognise that the model of harm minimisation, substitute medication being the primary aim, is changing, it's evolving somewhat. So that there's a move towards more therapeutic approaches, pharmacotherapy. There's this concept called recovery, which is different from the sort of recovery that Geraldine would understand in mental health. It's recovery in terms of becoming drug-free. The idea that there is a therapeutic edge to what we do in addiction services that help people to move from addiction to a state of greater health, free of addiction, if at all possible. That is not possible in all cases, of course. In medicine, we're very clear that quite a lot of people don't get better from their conditions. What we want to do is push people, support people, encourage people to go to a state of recovery, whatever that means to you. And I think there's also an increasing emphasis on integrating medication with other aspects of psychological and social intervention, rather than seeing medication as something separate. That Cartesian dualism, the last slide from the last presentation, the idea that mind and body are somehow magically separated in people with addictions problems, is clearly nonsense. And actually ignoring that has led to the sorts of harms that are increasing in both mental health and addiction groups. Improving rapid access to treatment is important. Providing that outreach, that accessible treatment, services that people will use, will come to, rather than those that they feel they want to avoid. We have to integrate harm minimisation, not lose it though, because harm minimisation has been a major success, certainly in terms of HIV and hepatitis B, maybe less so in terms of hepatitis C because of the nature of infectivity in drug-using groups. These are painful processes because, of course, in red we have recommissioning, retendering. My service outside London, as it happens, was retendered. We lost the contract. They decided that actually the organisation that won the contract couldn't provide the service. So they said, well, would you go into partnership? I said, that's very interesting. Why didn't you think about that before? The commissioners clearly wanted a different model. They wanted different people. They got the same people. They got a slightly different model, which was only really partially successful. It led, though, to massive destabilisation of links between the addiction services, including the voluntary sector services, which also were lost in that process, and the NHS services such as hepatology services. And that's the difficulty. Losing those links, losing those personal contacts, losing those treatment pathways, which may have developed organically, but were starting to be codified in terms of treatment pathways for patients with hepatitis C and addiction problems. Having said that, it's also an opportunity for innovative service models. It's also an opportunity for extending partnerships. We have to work in collaboration. The whole has got to be greater than the sum of the parts when it comes to dealing with addiction patients with hepatitis C in particular.